question for Dr. Fuchs about how often do you think you see low-grade communicating hydrocephalus? We talked about a number of different factors. I was, not being a neurosurgeon, for lack of anything else to do, I was impressed over the years at how oftentimes patients would respond to acetazolamide in low or moderate doses to headache relief, even though they had no papilledema. We may or may not do a spinal tap, but oftentimes we would do spinal taps at a time when I was doing them myself and really observing what was going on. And a lot of times the CSF pressures would be in a range of 225 to 250, sort of borderline for what anybody would consider shunting, but really not oftentimes what you would see with real pseudotumor, which would threaten vision. But a lot of these patients would improve with with Diamox. And I think that's oftentimes a situation that is present. I just wonder if anybody else has any observations about that.
No, I think so. I think that when you look at how severe symptoms are, what the scans look like, again, as I think all the speakers have talked about, what exactly triggers us to look at doing surgery. Surgery is irreversible. And if there's things that we can do short of that, say medical therapy, and Diamox is certainly an option to try and see. And if patients get better and it's a prolonged response, they can do quite well.
Just as a corollary to that, in talking with Dr. Miller years ago, he alluded to the fact that maybe in other Chiari circumstances where there might be abnormalities in the arachnoid granulations as a result of long-lasting increased intracranial pressure. So one of the thoughts of a communicating hydrocephalus is that perhaps nobody's looked pathologically, for a lot of obvious reasons, at the arachnoid granulations and whether that might be not only venous obstruction, but actually absorptive abnormalities in the arachnoid granulations subject to pulsatile damage before relief of CFF obstruction at the foramen magnum can be done surgically.
No, I think that's true. I think the more we learn, in some ways we find out how much we don't know.
Anybody else have any questions? Yeah.
I wanted to ask, make sure that the answer to the question that this gentleman said was clear. You're not saying that decompression of someone of the Chiari and a patient with a empty cella will help?
No. In terms of pituitary function, no.
Well,
No.
If you have, I believe that the question, and I'm sorry.
Yeah.
Because I thought it was important.
No.
The question was, did that respond to
Chiari decompression? No. That's a pseudotumor. In fact, no. That's. I'm sorry if that was unclear. No, that's a pseudotumor, and that was the whole point of that slide. Was when you look at that and see that, take your, you step back from the Chiari and look at. That's a clue that there's something else going on. And no. I don't know if I made that. I'm sorry if that was ambiguous, because the whole idea there was that takes you down a different road. Right.
Absolutely no flow out of the fourth ventricle of my brain. I had a 25 millimeter herniation on one side, 22 on the other side. And then I had the decompression, but I also had empty cella, which was founded, Dr. Kola, was 2005.
Yeah.
All right, and that wasn't founded until we went in. And I now have all sorts of thyroid issues, but that was never founded until later on.
Yeah. No, that's a separate. That's a separate issue.
I was wondering if that decompression had anything to do with all of a sudden that's no longer founded on an MRI. It's like, oh, you don't have anything to sell anymore. It's done.
No, the decompression won't treat that. Yeah.
So it was just weird.
Just not a very studied observation, but a casual observation that the empty cella generally doesn't improve after decompression. And oftentimes the pituitary function is not very well impacted. I mean, we look for first gonadotrophin abnormalities, and then thyroid abnormalities, and then maybe others. Thyroid abnormalities, particularly in women, is very, very common over the age of 40, usually on an autoimmune basis, so not necessarily on a pituitary malfunction basis, but that can be worked out with appropriate endocrine tests. But empty cella by itself, I don't know, maybe the neurosurgeons have a different experience. They oftentimes find pituitary abnormalities or not. Does anybody have an opinion about that?
Usually not.
Yeah, we usually look for it, but I'm always amazed that we don't, even when it looks like, that one picture you showed was very, very graphic, there's almost, looks like there's no pituitary, but pathologically it's puddled, so the pituitary is kind of pushed to the sides and generally doesn't seem to be impacted in terms of necessarily its own volume. I don't know.
Yeah, and typically the cella itself is bigger. It's not just there's a lot of, the pituitary gland is getting crushed at the bottom. The cella itself is enlarged. Yeah. And so the pituitary is kind of sitting there at the bottom, and even though you decompress it, it doesn't just come bounding back and then refill that. It's a bigger space than normal as well.
I have a more complicated question for Dr. Maynard or anybody who wants to answer it. Have you looked at kind of the degree of congestion of venous sinuses, or is that even feasible to see kind of, oh gosh, I hate microphones, kind of differentiating maybe symptomatic and not, or if that's even considered? And I know some have one side kind of more congested than the other.
Yeah, well, it's very common in Chiari patients and patients without Chiari malformation to have one side that's bigger than another. That's not abnormal. That's just the way we're built. We do always look at the venous sinuses when we're doing an operation. I pay attention to that just because we're going to open the dura, and I like to know what the venous drainage patterns are and make sure there's nothing unusual going on. I think, obviously, as Dr. Fuchs was talking about, there is an overlap between people who have pseudotumor and Chiari, and there's an overlap between people who have pseudotumor, which is primarily driven from venous sinus pathology. Obviously, if you obstruct your venous sinuses, that's going to elevate your intracranial pressure, and you're going to get diagnosed with pseudotumor in many cases. Having said that, for a typical Chiari patient, I don't think that venous sinuses are a major part of the pathology.
Hi, my name is Jake. Just a quick question about syrinx. When it's very subjective for the patient if the syrinx is stable in your spine and you're starting to get a little bit of symptoms, but when are you start looking at engaging in surgery when symptoms get worse? How do you educate the patient on encouraging to express their symptoms and you make those decisions?
That's a great question, particularly for patients that you're following, because that's kind of what I was talking about earlier. It's very important to have the patient on board, and the syrinxes do change over time, and it's very important radiographically, because I'm sure, I don't know if you have a syrinx, but the first thing you generally do is you look at the report, because you get reports now and you see, change in configuration, and it's usually numbers. So to me, and I'd be interested in what the rest of the panel is, the shape of the syrinx is important, but the first thing is symptoms. What are the symptoms that are changing? Are they directly related to the syrinx or not? If it's headache or things like that, not so much. If it's sensory or motor, that's what I'm really more focused on. But the shape of the syrinx is also important. Generally, when they're getting under pressure, getting bigger, I'm more worried about it kind of getting larger and concave as opposed to linear. Because over time, a lot of times, that's actually as the pressure goes down, though, if you measure something like this versus this is a bigger number than this, but this is actually telling me that the pressure is probably going down a little bit.
Yeah, I would echo. I think most of us pay a lot of attention to the diameter rather than the length, and that's one of the distinctions we want to get into. So when you're doing 5 millimeter cuts, it's common you'll see a 3 millimeter dilated central canal that looks, or 3 centimeter, it looks 6 centimeters the next time. But if the diameter remains 1 to 2 millimeters, it would be hard pressed to blame that on symptoms.
That's That's right. Just from my own standpoint, I think diameter is very important, but also location in the spinal cord is important. At least when you're talking about pathology, pathophysiologically, Chiari causing a syrinx. So if you're talking about doing a Chiari operation, I want to see that the syrinx is relatively high up in the spinal canal and wide. If it's a lower syrinx, I'm looking for other causes, other mechanisms.
I've heard it said that no one dies of Chiari. So my question really is, would you ultimately face paralysis? Is that the outcome of Chiari and Syringomyelia? Because I was treated, I guess, back in 1987, and just to use words that I remember from my report, I underwent decompression, fourth ventricle shunting, laminectomy, and I think they put 2 shunts in there. And it's been good, but then slowly I'm seeing again, a loss of function. I mean, gradually losing use of my hands and sensations, So I'm just wondering, is that leading to paralysis, ultimately?
I think it depends what you define as paralysis. No, nobody's going to be on a ventilator and in a wheelchair, but you can't, our concern is that you may have gradual progression of decline in neurological function. So when you're seeing something like that, you certainly need to get new images and see the physician. So the concern is when, the answer we don't know, the question we don't know the answer to is when do symptoms become permanent? When is it irreversible? We know in general, the sooner things are addressed, the better the long-term outcome. So then you want to make sure that you're addressing things in a timely fashion, but not prematurely, meaning that if it is a minor issue that can be followed, and that's part of the discussion with patients, because what may be minor to one may be debilitating to another.
But what's interesting is I get my MRIs every 2 years, and all the while they tell me, oh, you're stable, but I'm feeling these things.
So now I'm going to go on me personally. That's the setting I do the Cine MRIs, and I try to see if I can see anything else going on there. You may even want to see neurology and consider EMGs or some functional status, but now we don't want to get into personal stuff, but your hands have a little atrophy that Dr. Viz was talking about there, just looking at you.
Yeah, and also, I completely agree with them. The Cine